I want to welcome you to the fourth of our series this month, Mayday Mayday series on workplace mental health and injury prevention. I'm very excited about today to talk about some research results and research in progress, and about how and discuss how ways we can find and build on the knowledge that that researchers bring to us, and how we can translate that and mobilize that for prevention, which is what we all really care about. So we have three speakers today, and I'm going to introduce the first one, who will be starting, who is Dr. Behdin Nowrouzi-Kia from University of Toronto. And he is an occupational therapist and assistant professor at the Department of Occupational Science and Occupational Therapy. There, he holds the inaugural Emily Geldsaler Grant Early Career Professorship in the Workplace Mental Health. Dr. Nowrouzi-Kia is also an affiliate scientist at the Krembil Research Institute at Toronto Western Hospital University Health Network, and a collaborating scientist at the Center for Addiction and Mental Health. He was also the founder of the Infinity Health Consulting Group and OT Services North. Do you want to start sharing, Behdin?
Absolutely. Thank you, Valerie, for that kind introduction. Maybe what I will do is now share my first slide. Hopefully it's a little bit bigger on your screen. I changed the display so you get a more fulsome image. Is that okay?
Yeah, it looks good. Thanks.
Okay. Just confirming you can also hear me?
Yep.
Okay, perfect. Great. Thank you so much. I think I'll get started. So good morning, good afternoon, good evening, wherever you may be. Thank you so much for taking the time to join me today. I get to talk to you and have the great pleasure to talk to you about a little bit about workplace mental health. The title, Mindful Workplace Mental Health, Accommodations and Return to Work. We'll delve into a variety of topics related to workplace mental health and talk about the existing state of evidence. I will start out by telling you a little bit about myself, as well as my positionality, so you understand where I'm coming to this. Naturally, I'm a healthcare provider, so I have a clinical perspective to things. I'm also an academic. My primary appointment is at the University of Toronto, so I do research as part of my day job, but I also look at it through a very applied rehabilitation, occupational science, and occupational therapy perspective. So that's a little bit just to get you interested in what I'm doing. So some disclosures: I hold grants, industry grants. I also hold tri-council grants, as well as funding from the ministry. As well, I also disclose consulting fees that I get for some of the work that I do clinically. And alluded to, I also hold scientific positions at some of the Toronto Academic Health Sciences Network institutions, including University Health Network and CAMH. So I don't have any conflicts to disclose here with this lecture today. And what I'll be talking about will be evidence-based and evidence-informed. So that's really important. So what I will be presenting to you will be grounded in peer-reviewed scientific evidence. So a little bit about my group and my team. So I get the great pleasure of leading the Rehabilitation Sciences through Occupational Research and Engagement Lab. This is a lab that I founded at the University of Toronto and the Temerity Faculty of Medicine and the Department of Occupational Science and Occupational Therapy. And our mission is to identify, assess, and develop occupation-based interventions for preventing high-risk behaviors, optimizing function, and improving mental and physical health in the workplace. So our language is very deliberate. When we say occupation, we're focused on activities that are related to work. In this instance, we have a great emphasis, just as OCAL does, on prevention. We're also very interested not only on symptomology, but also on function, because we know clinically, as well as from the research, that really function equates to how people go back to work, stay at work, how workplace accommodations are utilized and implemented into workplaces as well. So if you're interested in learning more about our work and our team, please either scan the QR code or go to the website that's on the screen, restore.rehab, to learn more about us and our team. And I have an immense respect for the team members that I get the pleasure of working with on a day-to-day basis, and using an equity, diversity, and inclusion perspective. Really, we try to represent people, whether they're learners at the undergraduate, master's, doctoral, postdoctoral fellows that work with us, that are a reflection of the communities that we serve in Toronto and Ontario and Canada. So we are very deliberate in ensuring that those considerations are made, and we are very proud of our equity, diversity, and inclusion statement that's on our website. So if you'd like to take a look at that, please do so as well. Everybody puts their contact information at the end. I like to put it at the beginning so that in case you want to reach out to me, please do so. I'd be delighted. The last time I was here, I received a tremendous amount of engagement from the audience members, and I was thrilled to be able to connect with them, to learn, to share what we're doing here at the University of Toronto, as well as to collaborate together. So some of my affiliations are there. I'm also a faculty researcher in the Center for Research in Occupational Safety and Health. That's based at Laurentian University. So do engage with us in any capacity that you think makes sense. Or if you have any questions and you don't want to ask them here today, that's totally okay. Reach out to me. I'll be more than happy to talk to you. So what do I want to cover in my talk this morning, Toronto time, is that I want to explain the relationship between work and health and talk about why workplace mental health is so important and why we should be caring about this from a research perspective, but also from an occupational health and safety practitioner perspective, and I would say from a clinical perspective as well. Why is it that we need to understand why work and health are intimately tied together? What are some of the considerations around supporting return to work, accommodations? What does that landscape look like? I also want to identify some key principles and factors that are integral to supporting return to work, particularly with workplace mental health, and delve into some of the research that we've done and what others have done, of course, and talk about that. And then talk a little bit more from a practical prevention perspective about major frameworks and models around work disability prevention and management. So what are some of the tools that we can use to ensure that our workplaces are safe, that individuals are psychologically well, and that workplace mental health is a top priority and remains a top priority in workplaces as well? So that's kind of what I'll try to do. I believe it's an ambitious effort, but I like to be able to do that with you and discuss it further. So I want to start off by, and you may already know this, but Waddell and Burton in 2006 generated this seminal piece of work and book that really looked at the relationship between work and health. And naturally, we know that work is intimately tied to health. It's a social determinant of health. It gives us a sense of purpose. It can give us a sense of financial security. And there's a great deal of evidence in the literature from my clinical discipline and others. In fact, my clinical discipline of occupational therapy is centrally founded on the premise that engagement in activity, and in this case, work activity, is good for your health. Of course, there's always too much of a good thing as well. Overworking can lead to deleterious health outcomes. We'll talk about some of those related to workplace mental health. Underworking can also have issues where we use the term occupational deprivation, or essentially talking about not having fulfillment, activity, or engagement can lead to poor health as well. And this article and this book really highlighted some of this and conceptualized it together beyond the traditional avenues that I was talking about in occupational therapy, because maybe some of you are coming into this and saying, what's occupational therapy? Is it occupational hygiene? Is it occupational health? I'll get into that a little bit more later too. So they also looked at the relationship between work demands, function, and the benefit of work. And really what I want to highlight here is that there's a two-way street, that there is evidence to suggest that, the benefits of work are not just certainly limited to financial security or social well-being, but it's intimately tied to our common health. So if you have generally better health, you're more likely to be engaged in work, to be healthier. But if you have poorer health, you're less likely to be engaged. And you can see this with different types of disabilities, with episodic conditions, particularly workplace mental health ones. For example, major depressive disorder, bipolar disorder, these kinds of conditions that have mental health manifestation could be examples. Others that are more chronic and complex, like systemic lupus erythematosus, or lupus for short, has an episodic nature and has a deeply involved cognitive and mental health aspects that could also follow these types of trajectories as well. So if you're interested in this work, I invite you to kind of look at the World Health Organization International Classification for Functioning. So this is a framework that the World Health Organization developed many years ago. And I only provide this checklist as an example of applied and practice to you, looking at both the physical health aspects in this example and others. When I do these kinds of talks, questions come out, but does this also apply to mental health? Can we use the World Health Organization's ICF framework for mental health? And indeed, we can. Some of these examples with mental health is the one that I provided here. So the checklist that's at the bottom of your screen could be used to, for example, understand how to prevent workplace mental health issues, looking at the biopsychosocial framework that the ICF presented more than 20 years ago. And in this example from the ICF itself, it gives you the example of one where somebody may have a diagnosis of a particular type of mental health condition, and how does that impact their functioning? How does that impact their participation in activities? What are the biological and psychological considerations? But in addition to that, what is their environment like? What is the personal attributes of this person as well? So all of this landscape comes together to influence how we're going to, as occupational health and safety practitioners, as clinicians, as researchers, as allies, work together to understand and best support our workers so that they can stay healthy and they can stay at work, or they can return to work regardless of their ability. From my discipline of occupational therapy, we look at these kinds of same principles. Remember when I was saying a little bit earlier, I said occupational therapy was founded on this idea that functioning and engaging in activity is good for us as human beings. In fact, we argue in the discipline that functioning is integral to our health. And if you don't function, in fact, that leads to poorer health. So when we look at these three spheres, we recognize that there's the person and they have their unique attributes that we talked about, very aligned with the ICF. And we look at the environment as well. And that environment isn't just the physical environment. It's in fact a very broad term to look at the physical and built environment. It's looking at the organizational culture, the social considerations, the macro influences that dictate how rules and regulations are imposed. For example, how do Occupational Health and Safety Act get implemented? How does the Workplace Safety and Insurance Act look like in an environment of the workplace when it comes to workplace mental health considerations? And we also use this term occupation. Naturally, to all of us on the call here, unless you come from this discipline, you're going to be thinking of paid work. And to us, it does mean that, but it also means essentially activities of daily living. So how do we engage in our occupations so that we can fulfill the needs and wants and things that we need to do on a day-to-day basis? Sometimes in the health literature or in the occupational health safety literature, you might have heard of activities of daily living. Very much that is intimately, closely tied to our term of occupation. And when these three circles confluence together, we see that there's an optimization of what we call occupational performance and participation. In different language, you see this in the literature as well. Sometimes that looks at optimizing function. Maybe it looks at work performance. Anything that we can augment someone's ability to engage in work. This model, the PEO model that's been around now for about 30 years, helps us dictate that. And I find it's a very accessible model for people to kind of understand ways that we can look at workplace mental health. In addition to that, some of you may already know about the WDP framework. So we heard a little bit at the beginning that prevention is very key. OCAL is interested in this. The work disability prevention model gives us this framework or system that very much allows us to look at the healthcare environment, the organization, the legal and compensation systems, and the person themselves. And what I really like about it, because it applies so much to mental health and work, is that it centers the person or the worker in the middle of what we do. So you may have heard of patient-centered care, client-centered care. Very much the WDP framework espouses that consideration and looks at the totality of all of this when it comes to workplace mental health. Another framework that I think would be really important for us to consider when it comes to workplace mental health is the workability, and it comes out of the Finnish Occupational Institute, and really and it's been around probably for over 31 years or so now, and it looks at this ability or this construct of workability, or how well is the person able to do their jobs based on the demands and their ability to do them. So it looks at that kind of influence of all of these kind of factors. So if you look at this house that's on the screen, you'll notice that it has different floors. So at the base floor, and this is kind of where sometimes some of us as occupational health and safety practitioners, clinicians, researchers influence that base floor, looking at the health, the functional capacity of the person, and making sure that, for example, reach medical maximum recovery or medical maximum improvement. And I know not everybody agrees with those terminologies. And then maybe going to the next level is to kind of look at what their work experience is like, what is their previous learning, engagement, competence. And as you go up the ladder, you'll notice that there's different considerations. Lots of them have to do with psychological, attitudinal, motivation. And as you get to the higher up floors, you'll notice that there's a larger floor. So there's greater emphasis on the work environment, the work community, and the management as well. And all of these influence this idea of workability within the larger macrosphere of society, culture, etc. So I think that's really important, particularly when we're talking about workplace mental health, because the emphasis here is also on recognizing that environmental consideration. And all of these other frameworks that I've also discussed can be tools. And, when we teach our learners here, sometimes they ask us, well, which framework should I use? Like, is it one that's better than another? I would say another way to think about that is to consider that these frameworks can be used sometimes in conjunction, or other times one may be a better fit for what you're trying to do. Maybe there's a specific question that you're trying to answer, and the workability framework would be better. Other times, maybe the World Health Organization framework would be better, the ICF, and other times maybe the PEO would be more appropriate. And sometimes you may borrow from some of them and use that in your work. And I think that's entirely reasonable to be able to take the strengths, because all of them will have limitations. And certainly I don't have the time to cover that in this talk, but it's just to give you that orientation to what it could look like. So in terms of workplace mental health, why it matters is that we know that as a society in Canada, and even now globally, mental health is becoming more and more of a consideration, and more as part of the claims that are seen through compensation systems, as well as being one of the leading causes of disability in Canada. I mean, the numbers are outstanding. Just anecdotally, as a clinician, when I graduated about 17 years ago, most of the clients and patients that I worked with were more on the physical health aspect of things. They may have had, for example, an injury at work, and they were going to back, but it was something physically, maybe back pain, a type of traumatic injury, or so forth. Now I'm seeing the opposite, where much more of the claims that are presented, or the clients that I see, are mental health. And that's corroborated what we see as well. There's a growth in mental health claims. They're becoming much more pronounced. And there's also obviously greater awareness and appreciation of that. And some of that, why mental health matters, is that it influences productivity and job performance. It influences our mood and how we interact with one another. It impacts recruitment and retention. And so that's so important in so many aspects of our system. I mean, we look at the healthcare system as an example. This is something that is deeply, deeply involved with workplace mental health, because people will leave the system because of pressures related to burnout, to workload, to job dissatisfaction. And, as somebody who trains healthcare providers, to us, it's also very important, because what disservice am I doing to an emerging graduate, someone who has spent years and years training to become a healthcare provider, whatever their role may be, to go into an environment and then leave quickly? And this is what's happening. So this is why another reason why it's so important, and it goes well beyond health. I mean, we look at the housing crisis and what the federal and the provincial governments are doing, emphasizing that we need more housing. The same types of issues are seen in the construction sector, and so forth. So it spills over to many different industries. So workplace mental health has got to be top of mind for all of us, and in the research that follows too. Naturally, I think some of the risks that we have to consider is that I've alluded to. So I won't spend too much time around this. Just being mindful of the workload issues, the staffing issues, the relationship with work health. Naturally, that in certain contexts and certain settings, bullying, discrimination, and other equity deserving considerations must be top of mind. Job instability and insecurity, or job role clarity can all influence all of this as well. And some of the manifestations, some of the outcomes that we see may be related to burnout, job stress, depression, and anxiety, among others. It could also lead to poor work performance, decreased functioning, and so forth. And that's well documented. We've found some of that in the populations we've studied, and others have done so as well. So one of the questions that oftentimes comes up is, particularly with workplace mental health, is that you've got a client or a patient and you want to support them, and they may come to the OCAL clinic, and you say like, and they ask you these questions around, am I really ready? What if I'm not successful? Is there somebody that can support me if I'm not? What if I need more time? How will I be treated, particularly for workplace mental health? Because oftentimes they may be considered invisible, or they're not seen directly. And so, a coworker might say, well, that person seems perfectly fine. Why would we want them to get any special treatment? That's something that they may perceive. Other times it may be that the person is afraid of going back, and work avoidance might be the very approach that they take, because they think that if I don't go back to work, maybe I'll get better, and then eventually I can go back. And the evidence around that is fairly consistently saying that, unfortunately, that's not the case. So we know this already, but if you're new to this, certainly the return to work process can be one that can be deliberately set and involve many different stakeholders, including occupational health and safety practitioners. It can support sustained work. It can provide stability. It can provide a sense of purpose. Like I said, that functioning piece, the engagement in work, is therapeutic, and there's evidence to substantiate that for many, many decades now. Related to that. And why doesn't work avoidance work? Like, you might say to someone that has a major depressive disorder or some other type of mental health conditions, like, why is it that if you stay home and get better, wouldn't that make sense? Wouldn't they want to go back to work? The evidence that's been collected now for many decades shows that in general, the likelihood of going back to work declines over time. So, as a clinician, and when I teach this type of lecture to our learners here at the University of Toronto, we always say that if your clients are saying that they need more time, be able to explain to them, obviously not in the way that I'm presenting it to you, but to explain that staying out of work, regardless of the presenting condition, in this case workplace mental health issues, means that you're less likely to go back to work. And that becomes quite a bit challenging as we move forward to this together. So you'll notice that by the 12-month mark, so 1 year outside of work, the likelihood of going back is substantially lower, 1/3. So early intervention is key, and deliberate focused intervention is also important. And the evidence substantiates that as well. So just a question for you. You can think about it in your mind. If you want to engage in putting the answer in the chat, you can. I'll provide the answer shortly. Some of the interventions that we use, particularly around supporting people with workplace mental health considerations, could be vocational rehab. And there are 4 response options here. A is required for the majority of people with occupational injuries, including workplace mental health concerns. B, rather, typically involves providing only job support services. C, programs are at the individual level, but not the group level. So we're looking at workplace mental health concerns. Is it something that you can be deliberately done at a broader prevention level in an organization? Could you come up with education, advocacy, or even interventions that can look at the group? Or D, can address work instability and incongruity. So looking at the difference between one's ability and what tasks they have to do. And as you think about the response, I'll put the answer up. D is the correct answer, and you might think, well, why are the others not correct? And the short answer is that in fact, most people with return to work considerations, looking at workplace mental health issues or others, won't need vocational rehab. Thankfully, not. And the majority of people will go through a straightforward trajectory, although with certain episodic conditions, particularly those that have a mental health underlying concern, that journey could be a little bit more involved, but generally it can be successful. And notice that vocational rehabilitation involves a lot of different services. It can involve deliberate rehabilitation, physical or mental health. It could involve job coaching. It could involve training. It could involve lots of referrals to other services as well. And certainly it can be provided at both the individual and the group level. There's no issues with looking at prevention, not only at the individual level, but at the population level too. But the correct answer is that really when we want to use these types of interventions is to look at how it involves and addresses the ability of the person to do their job and what the demands of that job are. And vocational rehabilitation is exactly targeting that type of consideration. And there are many ways of doing that through more formalized assessment and treatment. For example, assessing someone's functioning, psychological well-being, and so forth, and then looking at how you can support them into a job or work place through interventions and treatments that could be a variety of types of approaches. Some of the ones that you may be thinking about include more deliberate focused, targeted and structured interventions like cognitive behavioral therapy, dialectical behavioral therapy, or engaging in work activities that are related to what their tasks are, particularly from a cognitive or psychological perspective. So those are all some of the approaches that can be done. I think we've already talked about this. My suggestion here is that regardless of what the condition is, in this case, when we're working at workplace mental health, the accommodations piece is a shared process that involves the worker, it involves the health team, it involves the occupational health and safety practitioner, and it involves discussions over time, discussions that look at how best to support the individual. And there are many considerations to look at. So for us, for me and others of you that are healthcare providers in particular, we look at this from a perspective of, is this person, one, medically stable? Functionally, what are they able to do? And then we can align and provide recommendations based on the restrictions, what the person shouldn't do, and the limitations, what they can't do, to the employer. And then we can sit down with our colleagues in occupational health and safety, in human resources, the managers and others, and come up with a blueprint. And that blueprint should include some discussions of what the Institute for Work and Health has published many, many years ago, and has been updated and is grounded in the evidence around these considerations. So being mindful of the positive work health aspects of it, being deliberate in providing the accommodations, there being return to work planning considerations, supervisors are trained, employers make early intervention and considered approaches, we identify people that are responsible for return to work, and that there's communication between these stakeholders. I also want to just touch base about some of the other tools that you may be aware of that are at your disposal as well at the much higher level. Notice that when I was talking about those frameworks, they all emphasize looking at the organizational structure and looking at well beyond the individual level. And some of these standards that are available through the CSA group look specifically at mental health or have mental health considerations within them. So I think from that perspective, the CSA 1003 and the CSA 1011 as part of the Occupational Health and Safety suite of standards are excellent tools that can frame discussion, they can provide with guidelines and approaches that can be used to support workplace mental health. 1011, for example, has an informative annex and an Annex B that has specific guidelines on how healthcare providers and occupational health and safety practitioners can work in this process of supporting return to work. This I've already talked about in terms of the ICF framework. Similarly here, from a preventative perspective, many years ago, one of my previous students and I wrote this paper in the Journal of Occupational Therapy, where we just emphasized the important role of all of us, and specifically we're talking about occupational therapy, but it applies to all of us in occupational health and safety and return to work, in emphasizing upstream approaches in the work that we do. So my take-home messages to you are that we remember the intimate and close relationship between work and health, and how that's tied to our mental and physical health as well, and recognize that there are many different factors that influence and contribute to workplace mental health. And I think that it's very important for us to be able to facilitate that return to work based on evidence that's there. And as occupational health and safety practitioners, we can implement and maybe tailor some of these frameworks so that when it comes to supporting our clients, our workers, we use a preventative lens, one that emphasizes their strengths and abilities, but looks at the considerations and the unique nature of workplace mental health considerations that sometimes are episodic. There's a waxing and waning, but and also recognize that each person is different. Because some of those CSA groups, psychological framework and guides, do that, provide that consideration. So I'll stop there. My contact information is there. I just want to make a short plug for any of you that are interested. We have the Occupational and Environmental Medicine Echo Group. This is a group that meets on a regular basis. The current cycle is active now. So if you're interested in learning more, coming to learn about occupational health and safety, about occupational and environmental medicine issues, please consider looking at this. It's hosted by the Institute for Work and Health right now, and we'd love to have you there, and you can search for it online. Thank you so much for your time and attention.
Thank you so much, Behdin. That was a fantastic amount of information, and we really appreciate it.
Sorry, it was a little bit too much. I apologize.
No, it's really good. And no, it's great, and no, we really appreciate it. And I think people will be, take value in going back and being able to listen to it again, and be able to review your slides, because I think it's so multifactorial. Yeah, I really appreciate you pulling it together. I don't see any actual questions in the chat, although Dorothy made mention of the CSA standard, which you also referred to almost simultaneously at the end. So I don't know if you wanted to make any further comment on it related to your presentation now, or.
I'll only, since Dorothy brought it up, I'll just say that I think great minds think alike, Dorothy. So thanks for bringing that up, and I agree with you. I think it's a great set of resources to put into our toolkits as we deal with these complex issues that are, like you said, Valerie, very multifactorial.
Mm-hmm. And it's actually being reviewed and updated right now. I was hoping to get a speaker to talk about that, but it's not quite ready. So that already we're planning Mayday 2026, because that will be very much a central discussion, I think. So, and Monica has a question about, is the timeline for returning to work over time the same for physical and mental health issues? That's a loaded question, but maybe a quick answer now, maybe.
Yeah, absolutely. I'll provide a short answer now. Monica, that's a great question, and one that comes up. The data that I presented comes from physical health outcomes. It comes from low back pain patients that were followed. So it's epidemiological data. When this looks at mental health or other considerations, it's unclear what that looks like. But we do know in general that early intervention is better. There's a hot topic around this with the people with lived experience that ask us with, and you may have some clients that have long COVID. So this question has come up to me as well. Does that look the same for them? The simple answer from an evidence-based researcher is that we don't know. But we can use what we do know to make at least some sort of inference as to what it could look like. I think early intervention is appropriate, but making sure that we look at the specific scenarios and cases. For mental health, I think early intervention is helpful, but being mindful that many of these types of presentations are episodic, so they have good days, bad days, and we have to be, it makes things a little bit more complex. I'll leave it there for now.